Good afternoon, everybody. I was just waiting a couple minutes there and hope that you're all able to get logged in. I see the participant numbers are still increasing. I'm Deborah Marshall. I'm a professor here at the University of Calgary. We have a very interesting and relevant topic today, and I'm really excited to be able to introduce our topic and our speakers. I'll first start with a territorial acknowledgement, and I'd like to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, and the Tsuut'ina First Nations, and the Stoney Nakoda, including the Chiniki, Bears Paw, and Wesley First Nations. And the city of Calgary is also home to the Métis Nation of Alberta Region 3. So today we're talking about COVID, and we're specifically talking about an initiative called 19 to 0. And it's a research initiative. It's around informing targeted messaging and direct knowledge translation through marketing campaigns, development of healthcare worker tools, and community engagement. I've had the privilege of being engaged with this team, and as I said, I'm really excited to hear them share what they're doing with you today. And we have three key people from the program who are going to talk today, and also I hope there'll be some really lively discussion. So in no particular order, Dr. Jamie Benham is a clinical research fellow here at the University of Calgary and in the clinician investigator program in endocrinology and metabolism. When this bio was written, I would have said she's a PhD candidate, but I think, Jamie, I can happily share that you're no longer a candidate because she successfully defended her PhD last week. So congratulations. Now it's completely public, Jamie. And Dr. Raynell Lang is a clinical lecturer in infectious diseases here at U of C and currently completing a postdoc fellowship in epidemiology at Johns Hopkins University. And finally, our fearless leader, Dr. Jia Hu, is a clinical assistant professor in public health at the university, and he's the co-chair of 19 to 0. So without further ado, I will hand it over to our presenters and really looking forward to the discussion. I'd also like to say that if you have any questions, we absolutely want questions. If you can enter them into the Q&A box, we'll work our very best to go through them at the end of the presentation. All right. Are you all set there?
Yeah, I think so. Thanks, Deborah.
You're welcome.
So, hey everybody. I think I'm kicking off, but I think this is mostly going to be Ray and Jamie's show. But I was going to provide a bit of an introduction to what 19 to 0 is, and sort of the high-level purpose of some of the work that we do from a research perspective. So, next, you can go to the next slide. Oh yes, I start with disclosures. So, I mean, essentially what 19 to 0 is it'll make more sense actually if you go to the slide after this, and then I'll go back to the disclosure slide, as I realize is a coalition of, people across society. This should include public health, government, academia, civil society organizations, private society organizations, that really is geared toward, I often describe, geared towards COVID-19 behavior change and vaccine uptake. Although realistically, I would say that we work in everything except for federal vaccine procurement. You go to the next slide after. I'll go back to the disclosures in piece. And I think this is, like a few of the partners that we sort of work with. I mean, there's a lot more than this. I think that it sort of came into existence in August, I think, as we're starting to hit our second wave, and I think that the reason why we have so many partners on board is because I think, effectively responding to COVID does sort of require an all of society approach, because we actually ask all of society to do things. Right now, that's sort of staying home and not really seeing anybody. It also sort of involves getting, all of society to, get immunized as quickly as possible. And so if you go back to that disclosure slide, Yeah, so I mean, we have received funding and or in-kind support, which is a lot like from a range of granting agencies, public health authorities and governments, civil society organizations, private sector companies, and unrestricted like researchy type grants from pharmaceutical companies. And so, I mean, there's a lot. And I mean, I think we have this model, sort of a network model, where we sort of all support one another. Please next, go back. Sorry, I'm making you drive all over the place. I should have, that makes more sense this way. And, I think that, fundamentally, I think that, this presentation will focus on sort of one of our big main work streams, which is like, effective marketing behavior change campaigns. I think that part of the like I do a lot of work with governments across the country, and I do think that they and public health authorities sometimes, often, I'll say, even have difficulties, I think, communicating certain things well. And there's a lot of reasons for that. But I think that one of which is that, communicating around COVID well may be one of the most difficult things to communicate well on, period, given the fact that, recommendations change quite quickly. Recommendations are very different from jurisdiction to jurisdiction. And, I think inherently, I wouldn't say that our sort of mass marketing health promotion approaches are the best they could be. I mean, I often, I think in public health land, I often think about people like Philip Morris as being quite good at selling certain things, or Jewel as being very good at selling certain things, or Coca-Cola as being very good at selling certain things. And, I think that one of the great strengths of pulling this coalition together when it comes to behavior change campaigns, you sort of like bring together, I think, sort of the best of what the academic and sort of like government side has, but sort of the best of what the private sector has been doing sort of in, because, they tend to have more money and more experience like selling people things, some of which aren't that healthy. And it's nice to sort of bring together all those sort of schools of thoughts and learning. We'll jump around a bit. Next slide. Next slide, partners, next slide. And so this slide actually basically covers sort of our 8 main work streams. We are going to focus a lot on the blue targeted population scale campaigns. And we'll talk a lot about the research and strategy side. I mean, I do think that it is quite critical that everything that is done in a way that is informed by data. Otherwise, you're just making stuff up. And there's plenty of that happening all the time. But we prefer to like use as much data as we can. I think that what does that generally mean? When it comes to the sorts of data that we collect, right now we're doing a sort of N of 2,500 weekly survey of Canadians on COVID uptake, COVID perceptions, vaccine uptake. And we also sort of are analyzing everything that one could analyze on social media. There's limitations to what one can get from Facebook. And all of that sort of feeds into our interventions, right? One of which is, the big marketing campaigns that Ray and Jamie will talk to. One of which is like a big healthcare worker education engagement. So we're sort of engaged, I don't know, like most of the health organizations in the country, to ensure that at least our healthcare workers sort of know about COVID, know about vaccine. And again, very, very, very difficult to keep up with this stuff. I often joke, you have the whole ministry summarizing the information for me every week, and I can barely keep up, let alone, an average, infectious disease doctor, let alone an average family doctor, let alone average lay public person, right? And so another one of our big work areas is what we call community and business outreach. And this is us essentially trying to connect with every organization, society, to support them with whatever they need COVID-wise, to answer their questions, to, nudge them to encourage their constituents to get vaccine. Again, all of this is very, very data informed, as you'll soon hear. And then, the last thing I'll point out under the targeted population scale campaigns is applying and testing behavioral science. I'll keep on changing the words of these titles, but essentially much of what we do is through, there's different, I'll call them axioms of thinking, right? And schools of thinking, right? And so I think there's a sort of a health promotion set of ways of thinking that falls within sort of public health. Oftentimes within the marketing world, there's you can go to the business school and they'll teach you marketing 101, which is another way of thinking about this. And then I think the sort of behavioral economics sort of nudge approach is yet another one. They're and we'll probably describe them more as just ways of thinking about problems and solving them. But we try to combine the best of all those things to sort of come up with both with our interventions. And that is ultimately all informed by sort of the data we collect and the questions we ask of people. So next slide. Yeah, and that's sort of basically who 19-0 is. And I'll like shut up pretty soon, but I'll just, you know, if you go to the next slide, I'll frame the problem real quickly. And so, you know, the problem writ large right now is, you know, like people don't necessarily listen to public health recommendations, you know, around COVID rules, like not going to people's houses when we have 2,000 cases a day, or when it comes to the vaccine, sort of like vaccine, you know, hesitancy. And I think that, you know, when we talk about facets of the problem, like these are sort of some of the underlying drivers of why people don't do certain things. Like, why doesn't somebody want to get a vaccine? Very few people are conspiratorial to the point where they believe that these vaccines contain, you know, microchips that Bill Gates can track you with. You know, and I think that, you know, on the far, like trust, okay? Trust is actually the biggest underlying driver of vaccine uptake. It's quite interesting, actually. It sounds sort of kitschy, but we have like a bajillion data points that suggest that to be so. And so, you know, when it comes to things like vaccine uptake, we see lower uptake in groups that don't trust government, regulators, public health as much. And so those would include people who are Republican, actually, right? So in the US, half of Republicans don't want the vaccine, and that's a problem. But it also includes groups that have reasons to sort of mistrust government on the other side. So, you know, people who worked at Cargill, where they had a very, very big outbreak. You know, racialized communities that have been, you know, sort of maybe hurt by government in the past. And, the trust is such a big thing. And again, that's why it's really important, I think, to engage all of society, because people, you know, some of them trust Dina, you know, some of them trust their pastor or mom, a lot of them trust their doctor, some of them trust their employer. And, you know, the more sort of trust points you have encouraging a particular message, the better. The other sort of interesting line, like fast component, and Jamie and Ray talk more, this is just concern, right? And this was blend fairly well into like a vaccine confidence framework, but by concern, we just mean like, how worried are you about COVID? So, I mean, there's some very, very strong correlations between like how concerned you are about COVID and like what you do, right? So again, very few people don't think COVID is real, right? Like that is a very small portion, but lots of people don't think it's a big deal, right? And when it comes to any sort of behavior or whatever we do, you know, in your head, consciously or subconsciously, because emotion is very important, we have these sort of like benefit risk sort of calculi that are happening in the background all the time. And so for people who don't think COVID is serious, they're much less likely to follow public health recommendations. And for people who think it's serious, they are. And, you know, I think that increasing the perception of severity of COVID is actually quite important, because it like can shift people's behaviors across any domain that public health, you know, asks, so like whether it's masking or avoiding basement parties and whatnot. And then the last is, I mean, I'm going to call it something other than behavior, but I mean, it has to do with like the ease or difficulty of following certain recommendations, right? I'll use Cargill again, right? Very, very good little case study in social determinants of health and trust and all these things. Yeah, so with that population, you know, you're getting paid $16 an hour, and you know, you got 3 kids, and public health makes you isolate. And, you know, if you don't have income support, you might not. And I would understand why you wouldn't do that, right? You know, early on in the rollout in Ontario, you know, some of the uptake rates amongst healthcare aides, personal support workers were sub 50%, because, you know, sometimes they have to take a bus 4 hours each way to get a vaccine. And that becomes very difficult for somebody who, you know, doesn't have a lot of money, doesn't have a car. And, you know, I think that sort of broadly applies to many of the other sort of behaviors as well. Those are the sort of things we ask people to do. And so, you know, insofar as we're able to build trust, increase people's perceived concerns, and I mean, operationally remove sort of barriers, then we will be able to sort of get people following public health recommendations as much as possible. And I mean, I think many of you know this, but like, I'll just say this again, like, we don't entirely make decisions rationally, right? Like for nothing, right? Like we float in this perceived rationality of science, but like, whatever car you last bought, you pick some specs, right? But then like you sometimes like this one versus that one, right? And the same goes for vaccines as well, right? And it makes sense. This is why, even though we know that the risk of a blood clot from the J&J vaccine may be as low, well, it's probably about 1 in 100,000 to 1 million. And we know that like you're likelier to sort of die in a car accident tomorrow than get VIPIT from a J&J vaccine. People are still scared, including healthcare workers who know those numbers cold, right? And this is where understanding some of the emotional or non-rational levers becomes quite important, and especially when it comes to developing some of those interventions. And so with that sort of priming, I'm gonna hand it over to Ray and Jamie. Happy to ask. So let's do this. Yeah, we need to target, anyways, the underlying stuff. But go ahead, Ray. Go ahead, Jamie.
Thanks, Josh. So today we are going to share the data-driven approach to addressing a key factor in ending the pandemic, which is adherence to public health measures, which are designed to mitigate the spread of COVID-19. So the 19 to 0 Coalition has been using a phased approach to develop a data-driven mass marketing campaign, which is designed to facilitate behavior change in terms of adherence to public health measures. And today we are going to focus on phase 1, which is the Alberta campaign. Alberta was picked as a test market due to the strong relationship between the 19 to 0 Coalition and community organizations, as it's really important to use community outreach in combination with the mass marketing campaign to have an effect. And so using the test market allows us to assess the impact of the campaign, and then the data gained from phase 1 can be used to inform campaign expansion in phase 2 and phase 3. So to understand the problem, as Joel laid out, we wanted to deep dive into understanding Canadians' attitudes and perceptions towards COVID-19 public health recommendations and vaccination. Public health measures that we were interested in looking at included wearing face masks, physical distancing, staying home when sick, avoiding high-risk spaces like crowded indoor gatherings, using either a contact tracing app like AB Trace Together or an exposure notification app like COVID Alert, and being willing to take a vaccine when available. So the Alberta campaign was informed by data collected in literature reviews, focus groups across Alberta, as well as a national cross-sectional survey. The overall objective of the Alberta focus groups were to identify ways in which public health messaging could be improved to facilitate adherence to public health measures. And specifically, we wanted to look at determining attitudes and behaviors towards public health measures to understand any barriers that may be in place, as well as to identify public health communication strategies to facilitate behavior change. So the focus groups were conducted in late summer. So for context, as everything is rapidly evolving during the COVID-19 pandemic, this was late last summer when case counts were low before the second wave. And we did 9 focus groups with 50 participants. It's also important to note that this was when schools were opening up again, and there were lots of concern about children returning to the classroom. The focus groups that we did were stratified by region within Alberta as well as by age group, and we had 7 focus groups from areas in Alberta with the highest case counts. So adherence to public health measures was felt to differ between age groups, with participants from all age groups expressing that younger people were more likely to congregate in larger groups of friends. And one participant said this: the hardest thing is just to say distance with friends. Like, people just like to hang out with people. That's just all it is. Realistically, at the end of the day, they go out with friends, whether it be big groups or smaller groups. People are hanging out with other people. That's all it is. When we asked individuals what the easiest public health measure to follow was, the majority felt that face masks were the easiest in public spaces, Although as this was when children were returning to school, it was felt a big barrier was having school-aged children wearing masks and ensuring that they had clean masks every day. And there was a concern about losing masks and then it would be difficult to provide masks for them regularly. Also, physical distancing was felt to be an easy measure to comply with the exception of a few settings like private parties or schools. And interestingly, there was a difference between ages with a lot of younger people in the 18 to 29-year-old group feeling that those of older age were less likely to wear masks properly or to physically distance. We also asked participants about attending indoor spaces such as restaurants, bars, and pubs, and the perception of the risk and risk tolerance varied considerably, although many recognized that there was some risk in going out to these places. One participant said, "Every individual has to manage their own risk and what they're comfortable with. It's a matter of managing yourself and what you're comfortable with and your own risk." Some participants reported that they actually felt safer in restaurants and pubs where there were good public health measures in place compared with, say, a grocery store or going to a school. And many younger participants felt that private parties were actually the riskiest type of gathering place because there weren't any public health measures in place. But despite the risks associated with attending crowded settings, many participants expressed a desire to continue to support businesses so that they would survive the pandemic. Participants were asked about staying home when sick. While many realized the importance of staying home sick and its importance in protecting others, they felt that the communication was quite unclear from authorities about when you could return to work after staying home sick and specific guidelines around how to stay home sick and what it meant to be sick with symptoms of COVID-19. Staying home when ill was felt to be difficult for persons who had to go to a workplace compared with those who could work from home. One individual said, "So come winter, if I actually get a real flu, am I going to still be able to do my job? Yes. Am I going to suffer while doing it? If I don't get paid, I don't have an option. So yes, I will go to work if I have to, with a mask, using as many precautions as I can. But unfortunately, that's the way my life is right now. I don't think I'm alone in that." There were mixed perspectives around whether individuals felt there was enough sick time for staying home from work, with some feeling that there was always enough sick time, while others reporting having no or not enough sick time to follow the public health measures. So we also asked participants if they had any suggestions for how we could help individuals to stay home when they were sick. And one individual said, "So to me, I understand the practice, but I think a lot of clarification around the practice needs to be cleared up, particularly with employers, so that they understand what they need to do in order to be safe for their company, but at the same time protect their employees so that they can basically survive." There were three main recommendations that came from the participants about how to help people stay home while sick. The first was that a culture shift is needed around going to work when ill. And while they felt late summer last year that it had started, there were still a lot of people that they felt you would not be able to convince to stay home if they were sick. Second, to ensure that people have enough sick time if they are unable to work from home. And third, it was really important to have supports for people in the event that they need to get groceries or run urgent errands, or if they're caring for people outside of their home, like elderly parents. Participants felt when we asked them about a vaccine that it could help to get them back to their normal lives. One individual said, "I think we need a vaccine because you need to restart to live like normal." In the context of timing, this was late summer, so no vaccines were approved at this time and we didn't have a lot of data, but we asked participants if a COVID vaccine were to become available, would you take one? And opinions were quite mixed. Some participants across all age groups felt that they would get one right away, while other participants felt that they would not take a COVID-19 vaccine. These participants tended to report that they didn't think that COVID-19 would affect their health or the health of their family members. And some participants, particularly those in the older age groups, were concerned about the safety and efficacy of the vaccines and felt that they would likely get one eventually, but they were going to wait and see what happened. Several barriers to vaccine uptake were discussed, including a lack of confidence that a vaccine would work and that it wouldn't do any harm. And a few participants mentioned that they had experienced side effects from the annual flu shot in the past, and this would make them less likely to get a COVID-19 vaccine. Another participant about the vaccine said it's kind of about protecting yourself and everybody around you. Some felt that a vaccine could be used to protect society as a part of getting things back to normal. And many participants who reported that they regularly take the annual flu vaccine felt that they would take a COVID-19 vaccine when it became available. And a few felt that when a safe and effective vaccine became available, that it should be mandatory for everyone to take it. We then asked participants about the two apps, the contact tracing app, AB Trace Together, and the exposure notification app, COVID Alert. Many participants were aware that there was a Canada-wide app, less were aware of the province of Alberta app, and many felt that it would be more appropriate to have a Canada-wide app, which could be used as people move between provinces. Some saw the contact tracing app as a good tool for preventing spread of COVID-19 and felt it would be helpful to know if you had been exposed or if people around you had been exposed. And some people felt that younger people went out more, so they would benefit the most from it. One individual said, honestly, I like the sort of level of normalcy we have, so I'm pretty much ready to jump on board with any sort of measure that is easier than like social distancing. There were a number of concerns about the app, though. Certainly the main concerns were with respect to privacy and security in the older age groups, although this was of less concern to those who were younger, who felt that they gave away a lot of their information in general using other apps on their phone. Some participants were also concerned about government tracking and surveillance, and there were a lot of misconceptions about how the apps work. So overall, participants described public health communication throughout the COVID-19 pandemic from when it had started to late summer as being quite inconsistent. And as a result, many expressed, as Ja had mentioned, that there was a lack of trust in authorities. A lack of trust in the government has been consistently associated with lack of adherence to public health measures and is a barrier with respect to taking a COVID-19 vaccine. The participants made a number of suggestions, which are shown here on the slide, about how to improve messaging with respect to public health measures. So they first suggested to frame messaging around protecting others rather than yourself, to provide more scientific or public health rationale for the importance of these behaviors so people could understand why they were supposed to do them and how they were helping, and to highlight the importance of these behaviors for society to return to normal. The participants also suggested that tailoring messaging strategies that were directed at specific population segments like younger people would be a good way to create the messaging.
All right, thanks so much, Jamie. So following these focus groups and informed from the data from these focus groups, our study team designed and conducted a national cross-sectional survey. This was active between October 27th and November 2nd and included nearly 4,500 participants. The survey was designed to evaluate intention to take a COVID-19 vaccine, beliefs about COVID-19 and vaccination, adherence to non-pharmaceutical interventions, so these were similar to the focus groups, so including physical distancing, staying home while sick, masking, and avoiding public places that are high risk, and uptake and usage of the contact tracing or exposure notification apps. The survey was conducted through the English Read Forum with eligible people being 18 years or older, speaking French or English, and having access to the internet. So here are the demographic breakdown of the survey respondents by Alberta compared to the rest of Canada. And we wanted to stratify for equal representation of Albertans and residents of the other Canadian provinces combined. So we sampled 2,000 from Alberta and 2,500 from the rest of the provinces. And this sampling strategy was used to allow for comparison of the two Canadian apps. So as we know, there's AB Trace Together in Alberta, and then there's COVID Alert, which was available to 8 provinces as well as the Northwest Territories. So looking at the demographics, you can see that between Canada and Alberta, the breakdown of education was very similar in our respondents. Essentially 1/3 were educated with a high school diploma or less, 1/3 had some college, trade school, or a certificate, and then 1/3 had either some university or a university degree. The majority of respondents in both Canada and Alberta were actually quite high income earners, earned over 100,000 a year, and this was slightly greater in Alberta. The majority of respondents from Alberta were conservative at 48%, whereas the majority of individuals sampled from across Canada were slightly more liberal at 40%. Across Canada and Alberta, the majority of individuals participating in the survey self-reported as being white. In Canada, 19% self-reported as a visible minority, whereas in Alberta, 14% did. So based on the data obtained from the survey and on attitudes towards COVID-19 and how it could potentially affect the health of the individual or their family, we established a concern index. So the higher the score represents the more concern that respondent expressed. This was done because we did find that concern one had for COVID-19 actually was quite significantly associated with their willingness to adopt public health measures as well as be vaccinated. And so we thought that if we could move someone from even the slightly concerned group to the concerned group, it may result in a behavior change and an increased likelihood of adopting individuals into 4 groups. There's the very concerned, the slightly concerned, and the not at all concerned. So from this concern index, we identified that about 18% of our respondents fit into the no concern group, meaning that they were largely non-adopters of the public health behaviors and not really willing to get a vaccine, but they did show some slight openness to movement. 30% fit into the low concern group, meaning that they were also non-adopters, but did show more willingness to move. 35% were primarily adopting, or the concern group, were primarily adopting the public health behaviors, but not always. So it did give us the opportunity to nudge them a little bit further towards further adoption. And then 17% fed into the very concerned group. So these people were very highly adopting all of the behaviors, willing to get a vaccine, and were highly motivated. We wanted to keep that motivation, but our marketing campaign did target the other three groups to try and improve adoption. So actually after this survey, we conducted a national focus group, or a group of national focus groups as well. And I just wanted to highlight a few of the quotes from this work, as it really does describe the range of attitudes and behaviors regarding COVID-19 and the public health behaviors. So this participant from Fraser Valley actually stated that, "I have a daughter that believes COVID is a scam to push prescriptions and vaccinations. I have another daughter who is completely concerned and doesn't do anything, doesn't go anywhere. So I'm trying to figure out what's real." So it just demonstrates that there is such a huge division, even within families, as to attitudes and beliefs about COVID-19 and vaccination. And so when we look across Canada, we can see those attitudes and beliefs are quite different. So further looking into this concern index, we can demonstrate that individuals' concern for COVID actually does impact their behavior. So here we ask people, in the last few weeks, how many people outside your household have you regularly interacted with? Persons in the not concerned group, almost 40% of them were interacting with more than 20 people on a regular basis outside of their household, whereas people in the very concerned group, 60% of them were only interacting with 1 to 5 people. We did the same looking at physical distancing. So it's also demonstrated in those that were not concerned, had quite a range of responses, but 30% of them said they physical distance rarely or never. But then when you look at the very concerned group, 60% of them said all of the time. So when we look at the demographics of these populations in order to develop archetypes to try and target our messaging towards, we have the no concern group. So those in the no concern group were mostly men, mostly under the age of 55, and 16% had a university education. The majority were conservative and high-income earners. They tended to report feeling more angry about the pandemic and about public health guidelines, and they were more likely to be focused on the economy. They tended not to live with anybody high risk. They were completely anti-vax and completely anti-mask. They did, however, report that they thought that staying home when sick and avoiding crowds would be effective to control spread of COVID, but they did not practice that behavior. They did not trust the government, but they did have trust in healthcare, and they relied a lot on Google for their COVID-19 information. Looking at the low concern group, these individuals tended to be more anxious than angry. They were predominantly female and predominantly less than 55 years old and high income earners. Only 8% felt that it would be serious if they got sick, but half of them expressed concern for their friends or family becoming ill. About 20% reported living with someone high risk. Half of these persons did report seeing more than 10 people outside of their household quite regularly, but 80% said that avoiding large groups would be effective in limiting spread of COVID. So it was a bit of a discordance there, and only half felt that masks would be an effective measure. There was quite a bit of vaccine hesitancy, with a quarter of them actually not wanting to be vaccinated at all. And then 30% of them disagreed with the statement that they would get vaccination to protect their family, but 60% disagreed that they would get one if their friends or family got it. So meaning that they wanted to protect their family, but they weren't really going to follow the leader. So here's just another quote from our national focus groups when asked about concern for COVID-19. So this participant from Atlantic Canada may have actually fit into this low concern group. So personally, I'm not too worried. I go about my normal day. It seems like most people are following public health recommendations, wearing masks and social distancing. I feel comfortable going about my daily tasks. So then lastly, looking at our concerned individuals, so this was 35% of our population. These individuals were again more anxious than angry, predominantly males, less than 55-year-olds. A third thought that it would be quite serious if they got sick, and nearly all were concerned about friends or family becoming ill. Nearly half lived with somebody high risk. A third of them were seeing more than 10 people outside of their household quite regularly, but nearly all reported that they thought that limiting large groups would be effective in limiting transmission. So again, a bit of a discordance with this one. 9 out of 10 reported following public health precautions. So overall, very good, but we could still nudge them a little bit further. And half reported kind of wanting to wait for a vaccine, but very, very few opposed it entirely. So some hesitancy there. They trusted their physician in public health, and they did receive the COVID information from kind of public health websites and briefings and things like that. From our surveys and focus groups, we identified this to be a very common sentiment, and this was stated here by a participant in the focus groups from the Atlantic provinces. So it's more that I don't want to give it to somebody else, not worried about my own health. So moving into our creative campaigns, from the information that we gathered from both the groups or the focus groups and the surveys, we set out to develop a creative campaign. 19 to 0, in partnership with Emergence Creative, has created the two following campaigns. So COVID is a Bear was launched with the intent to increase concern and seriousness for COVID-19, and Stronger Apart was to increase concern by acknowledging real life challenges and showing they are worth the cost. So these campaigns were both launched right prior to Christmas, actually in the middle of the second wave, and they were trying to curb the spread over the holidays. So I'll first talk about the COVID is a Bear campaign. So I've heard a lot of comments that it might not resonate with a lot of people. However, what we were trying to do was target the low or no concern population with this campaign. And so potentially it might not resonate with a few people or quite a few people listening in. But it was developed based on the archetypes of these individuals that we identified through our research. And we found that with early concept testing, it performed really well in these hard to reach high risk populations. So I'm just going to show you here. Let me just. All right, so that's our COVID is a bear commercial. And so overall, this campaign was actually very well received and very successful in engaging our target group. We had just over 1,200 link clicks, gained over 900 followers, and had over 400,000 3-second views, which is the number of times the video was played for at least 3 seconds, with 90,000 minutes viewed in total. And we had nearly 1.4 million impressions, which is the total times the ad was seen, and the paid impressions were over 1.2 million. So to demonstrate that this actually did indeed reach the target audience that we were intending to, we looked at what other pages the audience had also liked, and found that this was also liked by persons who liked the Oil Sands Action, Canadian Police Association, Canadian Energy Citizens, Sun Gazing, and Jason Kenney. So in summary, this campaign was effective and reached Albertans, most likely to spread COVID, was efficient as it reached our target population on a limited ad spend of just $15,000. We did get in-kind support running this as a commercial on TV. And it was targeted as it reached the population segments that were of lower concern that we were intending to reach. Our actionable item going forward was that we were going to target the no concern of the low concern segment for the campaign expansion, as we found that they were indeed reachable and we could make impacts if we could improve their adoption.
And our other campaign was Stronger Apart. So once again, the strategy behind this was to increase concern by acknowledging real life challenges and showing that they are worth the cost. So we'll show you this video as well. So for this advertisement, it also had the broad reach and engagement for the target populations with over 5,800 link clicks, 656 followers gained, and there were over 1.3 million total impressions. This one wasn't played on TV as it didn't, as the COVID is a Bear was the one that received that in-kind support. So we don't have the videos for this, but certainly it had good engagement. And so we saw with this that it was effective, it was efficient in terms of the ad buys that we had. The concept testing was validated and the campaign was felt to appeal to a variety of the archetypes that we had identified. And the recommendations in terms of an actionable item was to roll it out to broader segments. I'll hand it over to Ja to talk about what our next steps are with COVID-19 to zero.
Yeah. I think that we are, well, if I stick along this stream, I mean, I think at this point, we sort of built up quite a robust data collection mechanism, and it's not reported in this stuff, but particularly with our large and weekly surveys, with the ability to add modular questions per week, we've been able to detect things. We've got quite fun and useful, actually, like following nasty suspension of AstraZeneca, a 27 percentage point decline in AZ preference vis-a-vis mRNA preference. And then you combine that with the anecdotal stuff, like in Toronto, where like nobody in sort of the places like Jane and Finch, it's sort of like Forest Lawn, like wants AstraZeneca, similar decline sort of with the J&J vaccine following the ACIP suspension. And And, we are also able actually to like insert message testing, which is kind of cool. Like, how should we talk about AstraZeneca and blood clots in a sort of a mass marketing way? The answer is don't. Because, I think while we think about clots all the time, well, certainly I do, because people ask me that all the time, like, the public, like apparently isn't aware of it, which is, or many of them aren't, which is good. But, some of our, and so we continue to sort of use like that. I think that makes a very sort of robust survey instrument to the general public. I think to target, because we do a ton of work with like vulnerable populations. And, I think that we have partnered with a bunch of groups that sort of have the trust and work with these communities. And so we continue to get some data on these, sort of subpopulations. And, I think when it comes to what types of messaging works, there's also this huge cultural component to it, right? And so, there's a few campaigns that are coming up soon, and they're sort of time bound by the fact that you may have read in the news yesterday that the Ontario and Quebec will open up the vaccinations to all adults by the end of May, which means Alberta will do that too. And everybody else will, because we have the same supply. This is a grassroots thing. This already launched. Yeah. But in terms of the mass marketing stuff, we'll probably be doing like a fairly large Gen Plop uptake marketing type campaign, as well as a low-income essential worker campaign. And this was like a fun little thing we did with the sort of South Asian task force and like 4 other these sort of ethno-cultural national task forces, and they wanted to make a T-shirt, so we made a little T-shirt. And we had some celebrities like Ryan Reynolds, oh look, yes, you look at that, and it's pretty jacked in that picture, and some other people wear it, and Trudeau shot a little video and whatnot. I think the T-shirt campaign itself is like fun, but it needs to be linked to things that'll shift behavior, right? And so we had a large kickoff town hall on Wednesday night, I think. But yeah, no, lots to come. I think that. On the sort of mass marketing stuff, which is sort of what, Jamie and Ray have talked to, like there's big campaigns coming down the pipes, but I think that, our other work streams remain very robust still, right? And a lot of that is just connecting with groups and supporting them with whatever they need. A lot of that's educational stuff, because there really is, it's very hard to keep up. But it also includes sort of like policy things like advocating for on-site immunizations in different provinces, right? Advocating for like hotspot immunization approaches. And so, yeah, I think we do a bit of everything, but all that stuff is data informed. And so I feel like what time is it? Let's go to questions. Yeah, questions are funner.
Yeah, thank you so much, Jamie, Ray, and Xia. This is just fantastic. What's going on. A couple of questions. Well, we actually have multiple questions. I'm going to combine some in the interest of time, but we do have time for some questions, and I think people are anxious to engage with you here. But I think a key question that all of us would ask is, you showed some really impressive numbers in the 6 digits around can we reach the audience, or have you reached the audience, and how you've engaged them, and they're in the millions of views. I guess the fundamental question then becomes, so can you actually say that they've been these campaigns that you've initiated, or have they been successful in changing behavior? And there's also a sub question to this. You identified 4 specific groups around their level of concern. Or are you able to measure that within the groups as well after the marketing campaigns? I don't know who wants to answer. I'll leave it up to the 3 of you to decide.
You guys can go first, and I'm happy to answer, but if you want to start, just tell me what to do, Ray and Jamie and Deborah.
So I think I can try and touch base on the second part of that question, in that we do have, our team is, our academic team and our teams are working on how an appropriate evaluation strategy for our upcoming campaign. And what that might look like is serial surveys, so surveying the same population kind of multiple different times to really identify if that campaign is indeed increasing concern or changing their behaviors. And so we're definitely kind of ensuring that we're thinking about our evaluation strategy and how we can measure that these are changing behavior.
I think it's a really important question, though, that we need to be thinking about, certainly from the Alberta campaigns. All that we have is that what reach we had, that we were able to get to those groups that we were targeting based on the fact that they like similar pages, and that it definitely did have that reach, but we didn't have an opportunity with that campaign to measure and say, did you see the ad? Did this change your intention to do a certain behavior? And did it make you actually change what you were doing? And so by doing the serial assessments of individuals over time with the campaign coming up, we should be able to do that and see whether this undertaking has had an influence on making a difference in terms of behavior.
You're on mute, Gia. You're on mute.
Sorry, I thought I unmuted. Sorry. I would say those first campaigns were baby campaigns in terms of their reach, right? And if you think about like how can this type of thing be successful? One is your messaging needs to like be sort of effective to people, and two, it has to reach people, right? And by that, you know, I use an analogy. You could have the best drug in the world for cancer, but if nobody uses it, then it is zero population level impact, right? And for the first set of campaigns, we spent $30,000 buying social media ads, which is like a drop in the bucket, frankly. And for the next round, we're going to spend, like with the in-kind stuff, I think, with the free TV and radio ads, probably like closer to $5 million, depending on how much primetime coverage we have. And in terms, like, we are pretty obsessed about the evaluations. It's quite hard to evaluate, right? I mean, like, and if you have any ideas, like, I mean, we've talked to, there's a group called the Truth Campaign out of the US. They ran $150 million a year, like, smoking cessation campaign. And, you know, we met with them, and I think it's even harder to evaluate COVID because, like, what you have is like incredible exogeneity, right? Like, and as in, it's like the only thing that's in the news more than anything. Like, it's in the news all the time. Like, you have like different provinces shifting the recommendations, and there's so much there. And, you know, we've sort of like scoured, like, I would say many of the best minds all over the world to figure out how to do this. And we'll do it the best we can. But like, I think that, you know, it's a hard evaluation to do because it's not clean, right? It's frankly a lot easier to evaluate how good a marketing campaign works on Lay's potato chips, actually, because there's like less exogeneity, and that's usually the hardest thing to market, consumer packaged goods. I will say this, you know, I think that you need that reach for one, otherwise there's no huge point. Like, the engagement itself speaks to the fact that this can like get people to shift their behaviors a little bit, but are you like attributing population level impacts to this versus like the 10,000 other things that can happen, like a lockdown is difficult. But I think that this type of thing is incrementally useful, like, because I mean, examples of campaigns being useful would be Donald Trump getting elected. So like his strategy, basically, like in terms of like his like election campaign relied on fairly shitty, but like highly targeted ads, right? To like what you might call his base, right? And, you know, that was like sort of well known to drive his popularity in many ways. And, you know, there is a reason, I think, that, you know, companies will spend $5 million on a 30-second Super Bowl segment, right? Like, and, you know, if we were evaluating like the impact of this on like a shingles vaccine, that'd be incredibly easy to do, actually, I think, right? Like, but for this one, it'll be a bit hard because the exogenate, like, it'll be, you know, if you have any ideas, let me know. But it's sort of like causal inference with great exogeneity. But, you know, we're gonna try our best.
Okay, thank you. Maybe we can move on. We have other questions here, so let's try to get through a few more in the last minutes. Key question. What and how, or what is the theory behind these interventions? How do you decide? How do you frame them? And what is the underlying theory that drives how you create these campaigns in 2 minutes or less?
I mean, I would just say that we combine a number. I mean, there's this like, you know, Deborah taught me about this thing, the theoretical domains framework, which I think a lot of the marketers sort of scoff at a little bit. You know, but I think what we do is we combine multiple theories, right? So like that's one behavior change theory that like, frankly, is like way too many sub-bullets, I think, with sort of like what marketers do, which is like, just like I mean, their main thing is like segmentation, right? Like, and like finding the audiences. And then on the behavioral econ side, it's sort of like different cognitive theories that we use, right? And you sort of mash them all together. And then there's still an art to it, right? Like it's you know, I mean, we can segment like the crap out of people, but like when it comes to like, why do we use a bear, or like this sort of like nationalistic trope, like, you know, that's where the art comes in. But yes, it is underpinned by, I think, a number of different types of like, you know, what you might call like theories of change.
Okay, thank you. Let me try this one, because you've mentioned contact tracing apps, and we all know there's an Alberta one and a national one. People have been asked to download these. What would you say, or can you provide some information about whether or not that's been successful? How many people have downloaded it? What are the benefits? Have you actually been able to observe this?
Yeah, the app's really interesting, right? So, I mean, I would say that the apps currently in existence in Canada are very useless. And they're useless because uptake isn't high enough, right? Like, I'm always, when these apps first started, I sort of always said, it's like, what do I call it? A long shot with high uptake, like sort of like a long shot with like high upside, right? So, I mean, you know, I think right now, A/B trace together, maybe 10%, COVID alert, 15%, whatever, right? Like the utility, you know, is like you'll capture the proportion of contacts that's equal to like the square of the uptake. And I mean, I don't need an evaluation to show that it's not going to be particularly useful for contact tracing, given the uptake that we have. And I think that, you know, the good news in a way is that like a year ago, I wasn't sure if any country could get their uptake high, but some have, like Singapore has 70% uptake with their solution. You know, I don't know, like, I think that after this wave, we'll be pretty much in the clear. And so I would say that this one is sort of like we probably like failed. You know, I think that like making these apps is pretty darn easy, right? It's all about the uptake or the behavior change that's hard. And, you know, I'll put it this way. At the end of this whole COVID response, like we will have like privately funded like more marketing dollars than probably all the provincial governments and federal governments put together, which has been insane, right? Because they had a whole lot of money. Like 5 million is a lot, but it's not a lot with $350 billion deficit. And I like to say that, like, you know, like it is what it is. Like I do a lot of work with Alberta Health, like in like the federal, whatever, CDS. And I think that we had to try a bit harder, and we didn't quite try hard enough, at least in, you know, the domains where we needed to like to drive uptake. A lot of reasons for that, but, you know, that's why we gotta get the vaccine uptake right. You know, it is more important than the app. So.
Yeah. Could you, we only have a moment. Are we able to answer this question? I guess Liz is telling me no, we have to wrap up. There are also some other questions here that participants have asked about children and specifically the types of theories, etc. And Liz advises me that any unanswered questions will be sent to the panelists, and Ray, Jamie, and Gia will ask you to answer them actually in written form to the people who asked, if you're willing to do that, because they're keen to get their answers, and we'd like to be responsive to that. Is that okay?
Yeah. I like for like whoever me asked 1257, I will say this, right? Like you gotta realize that, like, so I personally am quite a fan of like explaining why we do certain things, right? And you gotta realize that government I don't know if you've ever worked in like for a political party or in government, right? Like there is somewhat of a inherent conservativeness in how they message things out, right? Like they're cautious. They try not, like, they don't necessarily share a whole lot, right? And, you know, even if we had, I mean, I think, again, it's relatively easy getting the signs showing that we need to be more transparent. Like the real work in my world is like, let's say we have that, like, how do you convince government to move on it, right? And I think the same applies to the Ontario Science Table, work with those guys, like BC people too, right? It's like, how do you shift cabinet's decision-making? And you know, that really has been, I don't know, that's been, you know, the root of many things. I think, for better or for worse.
All right. Thank you. I'm afraid we're past the hour and people are needing to move to their next sessions, but I'll virtually thank all of you. We had a large participation in this session, and I know there's a lot of interest. So Liz will be sending you those unanswered questions so that you're able to respond to the participants. Appreciate your time today, and thank you to all the attendees who were able to join as well. Thank you. Bye-bye.
Thank you, Deborah. Thank you, Jamie. Thank you, Ray.